All right, today we're diving into a real medical puzzle, one that affects millions of women, but honestly is often completely missed: bladder outlet obstruction. Now, you might have heard of this in men. It's a pretty well understood condition for them. But in women, well, that's where the diagnosis gets a whole lot more complex.
So this really begs the question, right? Why is this such a tough nut to crack for both doctors and patients? The symptoms are incredibly common, but the actual cause? That's often hidden in plain sight.
Okay, let's just look at the numbers for a second. There was this huge study, the EPIC study, and it found that almost 20% of women report voiding symptoms, things like a slow stream or having to strain. But look at that much bigger slice of the pie. A whopping 59% report storage symptoms, like feeling the urge to go all the time. The real problem, the mystery, is that connecting these very, very common symptoms to an actual physical blockage has been, historically, just incredibly difficult to do.
And this slide really lays out the challenge perfectly. The symptoms are just a confusing mixed bag. You've got the classic signs of a blockage, like a weak stream, but they're often all jumbled together with these storage issues, like urgency or having to wake up at night to pee. This messy presentation makes it really hard for a doctor to just look at the symptoms and say, aha, it's an obstruction.
Okay, so if we do suspect a blockage, what are we even looking for? Who are the usual suspects? Well, it turns out the causes generally fall into two main camps. Let's break this down with a simple analogy, because it really helps. On one hand, you have anatomic obstruction. Think of this like a physical kink in a garden hose. Simple, right? Something is physically blocking the flow. Maybe a dropped bladder from pelvic organ prolapse, or even scar tissue from an old surgery. Now, on the other hand, there's functional obstruction. This is a bit different. It's more like having a faulty spray nozzle on that hose. The plumbing itself is fine, but there's a coordination problem, where the bladder neck or the sphincter muscle just fails to relax and open up when it's supposed to.
So, with this whole complex set of symptoms and a couple of different potential causes, how do doctors actually figure out what's going on? How do they uncover the truth? Well, they have a specific playbook they follow to solve the puzzle.
So the investigation, it kind of follows a clear path, starting simple and getting more advanced. It all begins with a really detailed patient history and a physical exam. Next up, doctors will often do a simple uroflow test. That's to measure the speed of the stream. And they'll check the post-void residual. That's just a fancy way of saying they measure how much pee is left in the bladder after you go. But the gold standard, the test that really provides the hard evidence, is the urodynamic pressure flow study, or UDS.
So this urodynamic study, or UDS, what is it exactly? Well, you can think of it as the ultimate plumbing check for your bladder. It's pretty sophisticated. It measures two things at the exact same time: the pressure that the bladder muscle is generating to push, and the actual rate of urine flow coming out. By looking at those two things together, doctors can get concrete, undeniable evidence and pinpoint the exact nature and location of a blockage.
All right, now for the really cool part. Let's see how this all plays out in the real world, by looking at a few actual cases. This is where we get to be detectives and follow the clues to crack the case.
Our first case is a 22-year-old woman, and she's had a long history of problems with urination. Right off the bat, there's a huge clue. Her post-void residual, or PVR, was 425 milliliters. Now, to give you some perspective, a normal PVR is under 50. So, yeah, she was holding on to a ton of urine.
Okay, now let's look at the hard evidence. On the left, that's her UDS tracing. See that green line? That's the bladder pressure. Now look down at the red line at the bottom. That's the flow rate. You can see the pressure is climbing, but the flow, it's barely moving. And the X-ray on the right, the fluoroscopy, tells us exactly why. When she's trying to urinate, her bladder neck just fails to open up into a proper funnel. It's basically stuck shut.
So here's the key number, the piece that ties it all together. A bladder pressure at maximum flow, or P.Q max, of 26. When you combine that with a super low flow rate of just 10 milliliters per second, bam, that confirms the diagnosis. It's a classic case of what's called primary bladder neck obstruction, a functional problem, not a physical, anatomical one.
Okay, let's move on to our next case and see how the plot thickens. Here we have a 59-year-old woman with a really complex surgical history. And this is important. It included an anti-incontinence surgery using something called a TVT sling. And now she's showing up with those classic obstructive symptoms, a weak stream and having to strain to go.
And whoa, the evidence here tells a totally different story. Look at her UDS tracing. That green pressure line is way, way higher than our last case. The peaks are just huge.
This means her bladder is squeezing incredibly hard to try and push the urine out, and the image on the right shows us exactly why. You can literally see a kinked bladder neck, which, as the report notes, is almost certainly caused by that previous sling surgery.
The smoking gun in this case? A P-DET-Q max of 60. I mean, that is a very high pressure reading. It's basically screaming that the bladder is fighting against a major roadblock. This data, combined with that visual evidence from the X-ray, it solved the mystery. She had an anatomic obstruction, a physical blockage caused by her prior surgery.
Now, our third case is fascinating because it shows how this problem can be completely silent. This 67-year-old woman came in for a dropped bladder, also called a cystocele. And get this, she initially said she didn't have any urinary symptoms at all. But a quick check revealed a post-void residual of 325 milliliters. She was retaining a ton of urine without even realizing it. Crazy, right? Okay, now this is where a really skilled eye comes into play. At a quick glance, her flow rate of 17, it seems kind of okay, right? But look closer at that tracing. The bladder pressure, that green line, it goes up to 25, and then it just stays there for a really long time. The image on the right is the final piece of the puzzle, showing a large cystocele that's physically kinking the urethra from below. And this is the subtle but crucial clue. Her bladder contraction lasted for a full 60 seconds. That is an abnormally long, sustained squeeze, and that, even with a decent flow rate, was the key finding that supported a diagnosis of an anatomic obstruction caused by her prolapse. It's the perfect example of why you can't just look at one number. You have to see the whole story.
So after digging through these cases, what's the big takeaway here? Why does getting this investigation right matter so much?
And really, it all boils down to this. The challenge isn't just about having the fancy tests like UDS. It's about the skill and the technique used to perform the test, and, maybe even more importantly, having the expertise read the results correctly. The tool is only as good as the person using it, right? And this slide just drives that point home perfectly. Check this out. These are two studies from the exact same patient. The one on the left, it's a poor tracing from an outside study. It's messy, the pressures aren't calibrated correctly, and the diagnosis of obstruction was completely missed. But on the right is a repeat study, done properly. And there it is. The obstruction is now crystal clear. That is the night and day difference that good technique makes.
Which brings us to this really powerful idea from the source material. It really drives home that making a diagnosis isn't just about reading a chart. It's an art. It's about blending the patient's story, the physical exam, and the hard data from the tracing to finally see the complete picture.
And so we end up right back where we started. For this really common but super confusing medical mystery, is a better, more expert investigation the key to finally solving it? Well, the evidence we've seen today suggests that for so many women who are suffering, often in silence, it just might be.